Hello, welcome to a session of radiology, pathology, and orthopedics. Yes, I'm coming to you from the University of Oklahoma Health Sciences Center, and I'd like to discuss with you kind of some of the fun parts of coordinating care uh, and also some of the challenges that we face as we do that. But I think this particular case will emphasize the great importance of close communication between pathology and at the initial stages, certainly between radiology and orthopedics. So with that, let's launch into a little bit about the history. So this patient was a teenager who had, like many teenagers, very active habits. And at one point, while engaged in one of his passions at the local skateboard park, he suffered a fall that resulted in significant injury and inability to ambulate. So he came to the emergency room with some help, of course, and as you can see from these x-rays, he's got some significant challenges here. He's got a complex fracture that's displaced. You've got several fragments of bone. And looking here through his clothes, of course, you're seeing imperfectly the outlines of a fracture. Now, of course, in a young active teenager, you might think, well, that's just as far as it needs to go and no further thoughts. We'll just fix this, realign it, get things put together and not worry any further. But I think it's worth looking a little bit more closely at some of these to ask ourselves the question, was there anything here that might have clued us in to something more serious? And I think there are a few little subtle clues. The intertables of the cortex are a little bit expanded, a little bit altered here. And part of this, of course, is obscured by the clothing and the shadowing. But beyond that, there's really not much here to suggest that this is a pathologic fracture. So the choice was made then to use an internal fixation device. Obviously, you can see here a nice rod. And the patient began to get follow-up studies. So here at 6 weeks, you can see the device is stable. The fracture has been stabilized. There's some resorption and so forth going on here. As you'd expect, some remodeling to occur. At 3 months, that's still going on. There's not a lot of change here. A little bit of reaction here on the opposite table. But then at 6 months, this callus begins to look a little bit funky. It's still a little bit more like a callus, but we have some lucency and we have some expansion of the cortex here, as you might expect with some healing. And we began to heal in this defect here to a certain degree. So probably still on a course to be expected. So they tell him to come back at a year, and lo and behold, the next radiograph we have tells a totally different story. Because now we see not only do we have expansion on the lateral side, but we have expansion medially with lysis and destruction of the bone and additional defects that appear subsequent to the process. We can see this extends upward into the towards the shaft here. We don't know how far it goes, but we can certainly now raise the question of what is this? Well, what can do this? Tumor, of course, comes to mind. A lytic tumor, an infectious process, although he's not febrile, and other sorts of infiltrating processes. So Ewing sarcoma, Langerhans histiocytosis, lytic osteosarcomas, and so forth begin to come into play in this situation. So with that in mind, a very brave needle aspiration is performed to just get a little bit of a better idea of what's going on here. And from that needle aspiration cytology sample, we see bizarre atypical cells, big, chunky looking things. So it sort of rules out the small cell neoplasms and puts the money on an osteosarcoma as being the likely cause for this process. So then, what do you do? Well, obviously, had we known at the beginning that this was a neoplasm, a rod wouldn't have been placed and so forth. But once a rod has been placed, essentially this entire femur is potentially suspect or contaminated, including the nail holes. And so although we don't see tumor growing out of any of these iatrogenic orifices, the potential is there that such could happen. And so various options are considered, but ultimately it's decided that the entire bone needs to come out. And so the full femur is resected, and we can see here on the MRI scan and on the PET scan that there's a lot of edema fluid around this lesion, a lot of inflammatory and metabolic activity going on here that would indicate that the lesion is fairly extensive. So with that information in mind, he undergoes some chemotherapy, adjuvant chemotherapy, to see if we can quiet this down, shrink the tumor perhaps a little bit, make the surgery a little bit easier, and then go forward with that planned total resection of his femur. Well, I'll share with you some of the histologic features that we have after several cycles of chemotherapy. You can see we've gotten some degree of necrosis in the tumor, and this is more centrally in the bone, kind of around and away from the rod. But we also still have here a number of areas of quite cellular neoplastic tissue. And as we can see here at higher magnification, there is perhaps a sense that we have some degree of osteoid formation, although it's not really mineralized per se. And as expected, we have quite a bit of atypia, both due to the nature of the neoplasm and likely due to the chemotherapy. A lot of giant cells, a lot of pleomorphism in the cells now, of course, augmented by the treatment effects, and some areas of hemosiderin indicating prior hemorrhage and so forth. So one of the challenges, of course, here is defining the nature of the tumor, and osteosarcomas can have variable degrees of ossification. We know from the radiograph that this is not a very pronounced ossifying tumor, but I think we can see that there's enough sort of this material here that suggests osteoid with central atypical cells that the classification as osteosarcoma is established from this sample. Well, obviously with less than 90% necrosis of his tumor, that does not portend as good an outcome as one might hope for, in that the tumor is not terribly responsive to the therapy. We'll look at another section here that illustrates another point that I'd like to make with this case. Here we see that the cortex is entirely destroyed, and we just have tumor right abutting against periosteal fibrous tissue. Fortunately, hasn't penetrated into the surrounding soft tissues, but here's our margin, just a few millimeters and so forth. And again, we see this high-grade pleomorphic neoplasm, a lot of pink matrix, some hemosiderin and so forth. And then we have over here, obviously, some calcified tissue, so some bone. And this then raises the question, well, is this tumor bone, or is this related to his fracture, or is this other sort of bone? And I think there's a helpful clue here, which is one of the teaching points in this slide. So we have cellular tumor around the periphery of here, of this area. And you can see we've got these pleomorphic cells, some giant cells admixed with this, and then this more collagenous matrix, and then the bone. And notice here in this bone that the internal structure here is fibrotic, yes, but it lacks the degree of atypia that we see over here. The high NC ratio, the variable nuclear size and shape, angles, and so forth are not seen in this situation. And so even though this bone is not decalcified, we can see to a certain degree that this is woven bone that's merging with this fibrous matrix of the marrow. And we can infer that this is benign woven bone, perhaps related to the attempted fracture repair or other response to changes associated with the growth of the tumor. But we have here this little island of reactive bone amidst this tumor. And very often in these complicated pathologic fracture tumor cases, you may get this constellation of findings. And so you have to resist calling this the osteoid as in osteosarcoma, and rely on finding definite osteoid within the tumor cell areas proper, and appropriately interpret this reactive bone. This is particularly a challenge in some lesions that remodel and change the contours of the bone dramatically. Giant cell tumor, aneurysmal bone cysts, and so forth can have this sort of reactive appearance, as well as varying grades of osteosarcoma. Notice here that at the periphery of this tumor, and this soft tissue or other area here, we have really very little evidence of a treatment response, other than perhaps these slightly hyalinized areas with some residual giant tumor cells associated with this. So it's not the necrosing response that you'd like to see to chemotherapy. Well, that brings us to the kind of the wrap up on this case, and hope that this has been instructive for you. I think this underlines the intense need for careful communication between radiology and clinicians involved in the care of a case like this, and during follow-up as well, to maintain proper communication and potentially detect this sort of an issue at an earlier stage. So our final sign-out diagnosis was conventional osteosarcoma, complicated by a prior fracture, and therapeutic response less than 40% in the resected specimen. So with that, I'll thank you for joining us for this session. I hope that these digital slides are available, or excuse me, I've mentioned that these digital slides are available for your review. The link is posted in the comments below. And if you like our program, if it's helpful to you, please give us a like and maybe even a share with some of your colleagues who may also be interested. And of course, subscribing will ensure that you catch future releases from our channel as those become available, which we continue to intend to do for the foreseeable future. We're grateful to have you with us, and thank you again for your support, and see you next time.